Go ahead. Hi, Steve. Are you there? Steve, it doesn't seem like we can hear you. Are you there, sir? I apologize, everyone. It seems like we're having technical difficulty. Just one moment.
Getting me actually connected so you could listen. My name is Steve O'Neill, and glad to be with you this afternoon for our webinar where we're going to discuss implementing substance use screening, brief intervention, and referral to treatment in hospital emergency departments. We'll spend about the next hour, hour and a half going through the slide deck and talking in general about the concept of SBIRT, and then more specifically about implementing in emergency departments. And then at the end of the call, we'll open it up and have live discussion and question and answer, and you're also free either when we move to that segment of the presentation, you're free to either engage verbally, or you can also send questions throughout the webinar in the text boxes that are available there, and then we will get to those at the end. Again, my name is Steve O'Neill, and I am currently the director of the Georgia Basics SBIRT project in the state of Georgia. Prior to this position, I was the director of the SBIRT project in Washington State. And throughout my tenure on these two projects, I've implemented SBIRT and been involved in SBIRT implementation in between, probably 15 or 20 hospitals, primarily in emergency departments. So hopefully my experience and expertise will be of benefit to you today. We want to talk generally to start about substance use services in general, and how SBIRT is really conceptually different from what we have done historically. Those of you who have been around substance use or have provided substance use services in the past recognize that we've really divided or bifurcated our services really into two very specific areas. And the first of those is primary prevention, where we generally work with an adolescent population or a youth population with the goal of being delaying onset of substance use or precluding onset if that's possible. Subsequent to working with adolescents and providing a broad prevention message, we really then go right to the treatment side, where we provide time, cost, and labor-intensive services to patients who are already chronically or acutely ill. So those services are really very distinct and very separated. Where we try to stop it before it starts. If that doesn't work, then we sort of have decided we would wait for people to get either chronically or acutely ill with a substance use disorder, and then provide that time, cost, and labor-intensive care for them. And if you think about that model from a more visual framework, you see on the screen we have a red light and a green light. Really, our model historically for folks has been, once you are diagnosable by the DSM-IV with a substance use disorder, we really have a system to provide time, cost, and labor-intensive care, and the goal of that care is abstinence. And that's really the model. And treatment can be anything, as you know, from outpatient services an hour or two a week to something more intense like inpatient services for 30 days, residential services, intensive outpatient. Generally, those services are defined by the American Society of Addiction Medicine patient placement criteria. So we have that treatment system, and it's fairly robust in our country and has shown good results. But again, we've really focused on a very chronic or acute population, which is difficult to treat, expensive to treat, and our success rates with that population, while good considering the population, because the population is so acutely ill that you know, the rates aren't great, but they are when you frame that within the context of the population that we serve that is so difficult to help. So we have those people who are diagnosed with a substance use disorder. We want to provide them treatment, and we want them to be abstinents, and that's really sort of the framework that we use. Then we have another group of people, and these are the green light folks on your screen, and we really decide that since they don't have a substance use diagnosis, these people are really not problem people. And so we separate them out. And for those folks, we really don't have any intervention of any kind. We basically have nothing to offer them because treatment is really geared again towards the chronic or acute substance dependent person. So we have the no problem people who here are represented by the green light, and we don't provide an intervention for them, and our goal for them and our message to them generally is drink responsibly. Of course, the wisdom of allowing Anheuser-Busch to provide our public service messaging is certainly in question here, but really we really have in many ways subbed out our prevention messaging or our use messaging to the alcohol companies, and of course they always tell us to drink responsibly. And so we really have these two separate groups of folks. We have the substance-dependent folks who need treatment and should be abstinent, then we have the no-problem people who we provide no intervention for, and we ask them to drink responsibly. But of course we don't really describe what responsible drinking is. And if you were to canvass 100 people, you would get 100 different responses to what is responsible drinking. You can get everything from don't drink and drive, which is certainly a fairly responsible social choice, to no more than 3 a day, to just once a week on the weekends. So you get a variety of answers because we haven't really successfully defined responsible drinking for the public, and really have allowed, again, the alcohol companies to do our messaging in regards to what responsible drinking is. So the problem, the primary problem that we see when we look at this issue just generally from a sort of national perspective is people don't know how much is too much. We have not done a good job in informing people about how much is too much. We haven't done any real messaging around this. And so people really are sort of left to their own devices to make a subjective decision about how much they should or shouldn't drink and what is acceptable or not. However, we really do have objectively verified limits, and we know where problems begin and end. And the screen you're looking at now is from the National Institute of Alcoholism or Alcohol Abuse and Alcoholism. And studies, multiple studies have been done, and broad epidemiological research has been done on populations around the world. And what that research has done is really defined what's responsible drinking, or in this case, healthy drinking, or low risk drinking is another way to define this. For a healthy man less than 65, it's less than or equal to 4 drinks a day, and less than or equal to 14 drinks in a week. And for healthy women and men 65 and over, it's less than or equal to 3 drinks per day and less than or equal to 7 drinks per week. Now, the reason this is divided up into a daily and weekly count is because of acute and chronic. the implication here is if a healthy man less than 65 drinks less than 4 drinks at on any one day of the week, that their chance of harm, their risk of harm, is fairly small. In other words, they won't be acutely intoxicated. And so their risk of falls, their risk of traffic accidents, their risk of other trauma, other kinds of health things that may occur when you're acutely intoxicated, that risk is fairly low. And the weekly limit is really a chronic measure, that if a person is drinking more than 14 drinks per week, or for a woman more than 7, then that's when the potential over time for chronic things to develop. And whether that's gastrointestinal problems, throat cancer, there's a variety of other things that could result from that. So we really look at differentiating acute effects, intoxication, and chronic effects, which are generally impaired health of some kind or another. And so we do have very specified, very specific guidelines for what we could consider responsible or low risk or healthy drinking. Now, if we take our visual format a little bit farther, and we look at all the green lights, and we'll consider everybody in the U.S. population to be a green light person, that nobody in the U.S. population has a problem. And of course, for these green light people, we have no intervention, and really our message for them is to drink responsibly. But if we look more closely at the United States population, what we find is at any one time, about 4% of the population in the country is actually dependent. So these are people that are diagnosable by the DSM-4 as having a substance use disorder. And so you can see that our system is really built towards assisting the 4 people out of 100 that have a diagnosable substance use disorder. And so only about 4% of the population at any one time. And again, this is based on lots of epidemiological data and excellent research by the CDC and others. If we look a little further, what we find is that 25% of the population are actually drinking over those NIAAA limits. So again, we have a system that is geared towards the red light people, those who are dependent, which is about 4%, and we provide nothing for the 25% of the population that's actually at risk for a variety of psychosocial or healthcare problems based on their current substance use choices. And again, these people are frequently operating in the dark. They've been told to drink responsibly, but they've never been given any definition of what drink responsibly means. So that's actually about a 6-to-1 split. So for every one person who we can diagnose as having a substance use disorder, we have 6 people who are at risk for any number of psychosocial or healthcare problems related to their current substance use choices, but they are not, would not reach the threshold of a DSM-4 diagnosis. Now, clearly, what this fraction shows is that we've invested literally all of our resources in the 1 and done absolutely nothing for the 6. And again, those 6 are at risk for a variety of psychosocial and healthcare problems, everything from trauma, DUI, relationship issues, low productivity, other healthcare problems, certainly if they're diabetic or have a concomitant mental illness, other chronic healthcare conditions, then these can clearly be exacerbated, if not caused, by high-risk use. So again, now our visual looks a little bit more like a standard stoplight. And what you see here is about, at any one time, about 71% of the population are really at low or no risk for any kind of psychosocial or healthcare problem related to their current substance use choices. Those are our green light folks. About 4%, as you can see, again, are dependent. And then we have the 25% who are now yellow light people. These are cautionary people. These are people who are drinking over those limits, over the NIAAA limits, who are at risk for a variety of psychosocial and healthcare problems. And you can see that in our model, because in the old model we had treatment for the red light people, and we had nothing for everybody else. This really shakes out that those excessive users, and we now, in the SBIRT model, actually have an intervention for them. So you can see that if you are in the green light, and means you're currently abstinent or you're drinking below those limits, then we know that you're at lower, very little risk or no risk if you're abstinent clearly from any kind of psychosocial or healthcare related problem. We would provide you in our model, and I'll talk a little bit more about how we proceed here, but our model would be just to provide you with feedback. We would identify you as a low or no risk substance or drinker. And then we would provide you feedback. We would say, we would give you the information on what the limits are, encourage you to continue to do what you're doing, things like that. If you're in the 4%, if you're in the red light group or the treatment group, we would talk with you about the risks that you're involved in. We would not diagnose you because we do not do that in SBIRT. But what we would do is we would discuss with you the current situation, the risks, etc., and then we would attempt to refer you to a traditional kind of treatment model. And so we actually have the ability then to send people on to more intensive kinds of services if there's a need. But in our model, we also have, and this is what's important, a service for the 25% who are using excessively or taking risks with their health by drinking over the established limits. And for those people, we can offer a brief intervention. And we can also, for some people who are at the higher risk levels, I'll also offer brief therapy. I'll talk a little bit more about what those are. But the importance of this model is that rather than just lumping people either as having a problem or not, we recognize that a large percentage of the population, while not dependent and perhaps not currently experiencing any problems, are clearly at risk for those problems, and that those folks can benefit from a brief intervention, some brief advice, or potentially some brief therapy. Now, based on that model and knowing how the country, the population really shakes out across the country with that 4%, 25%, and 71%, what that means is if we could provide 100% cure to every substance-dependent person in the country, we still wouldn't even be close to curing most of the problems that substance use causes, because most of the problems are actually caused by the 25% who are using excessively and are never diagnosed as having a substance use disorder. A good example of this would be the state of Washington, where records have been kept for years on DUI. Since the 70s, and year in and year out in the state of Washington, 75% of all those who get a DUI do not have a substance use disorder. Now, clearly, these are people who have used alcohol excessively. They're intoxicated. They're driving. They have a psychosocial problem related to their choice. But again, the treatment system, as it's defined now, has no adequate intervention for these folks. And so again, if we could cure everyone today with a magic bullet, we would still have a huge substance use problem in our country, because we would miss those folks who are at risk for a variety of problems who are not diagnosable. So when we start to talk about in the SBIRT model about what the problem is not substance dependence. Substance dependence is one of many problems that is associated with excessive drinking. And so, again, in the old model, we really said that the problem is a substance use disorder for which you need treatment and should be abstinent. In the new model, in the SBIRT model, we say that the problem is actually excessive drinking and a litany of potential psychosocial or healthcare problems related to excessive drinking. So we'll now talk a little bit more specifically and move towards talking about SBIRT and how we might put this into and implement this in emergency departments. But it's important to recognize that SBIRT really is a new initiative, and it really is a systems change initiative. It really requires us to reconceptualize how we understand substance use problems. Again, moving from a model where dependence is the problem to moving to a model where we understand that there's an entire continuum of problems that can be either psychosocial or health-oriented. So we need to reconceptualize how we understand what the problem is. Then we need to redefine how we identify that problem. Historically, the problem has been identified in maybe one of two ways. Usually, the problem is identified when someone gets in some kind of legal trouble and then is referred through the criminal justice system and the judiciary into a substance use treatment facility. And so that's one way that the problem is identified. We wait for people to experience a psychosocial problem, and then when they're engaged in the criminal justice system, then we seek to get them help. The other way is when medical providers recognize that someone has a problem. They diagnose a substance use disorder. They note that in the patient chart. Maybe that patient gets a referral, maybe not. Maybe the healthcare provider talks to them, maybe not. But so we've really sort of, how we've identified it historically is either, it's always post-problem. It's always after a problem becomes so apparent that it's easy to see. So we have to redefine how we identify substance use problems. And then lastly, we need to redesign how we treat those problems, recognizing that the treatment system for substance use disorders is not effective for people who are at risk for problems, who may have low-level problems or have yet to reach that threshold of dependence. And so we really need to think differently about substance use problems, identify problems differently, and then treat them differently. So SBIRT really requires us to change almost everything that we do. And in our model, we recognize that substance use is a public health problem. Clearly, substance use has been defined in a variety of different ways as a moral problem, a social problem, a criminal justice problem, etc. But we understand that substance use is potentially the largest public health problem in the country, and that it covers a wide range of health issues, everything from trauma to cirrhosis of the liver and everything in between. And so by approaching it as a public health problem rather than a criminal justice problem or a social problem or a moral problem, it provides us with new ways to not only look at the issue, but to address the issue. And all of us know that how we conceptualize a problem will really drive how we try to solve that problem. If substance use is a criminal justice problem, then the solution for that is incarceration, jail, probation, etc. If it's a moral problem, then we understand that the solution for that is better morals. If it's a public health problem, then clearly we need a public health solution. And that's really what SBIRT provides. So, just in brief, here's the things that SBIRT provides wherever it's done. First, we identify substance use problems using a public health approach and universal screening, and I will talk more about that. The second thing we do is we provide progressive levels of interventions based on the level of need and motivation for change. Again, historically, the system really has been one size fits all. If you have a substance use disorder, you go to treatment, and if you don't, then we really tell you to drink responsibly. So we want to identify, using a public health approach and universal screening, we want to provide a progressive level of intervention to assure that we're gearing our intervention towards the need of the patient. And let me back up to that. So in the most simple, straightforward way, this is all SBIRT is. And it almost sounds too good to be true. We're going to identify problems using a public health approach, and then we're going to provide clinical interventions. So it's a very important, although sort of a fine point, but it's a very important point, that the primary goal of SBIRT is not to identify those who are dependent or have a substance use disorder and need higher levels of care. That we basically have, in many ways, a system for that. The primary goal of SBIRT is to identify those who are at moderate or high risk for psychosocial or healthcare problems related to their current substance use choices. And again, these are those yellow light people who have historically been missed by providers. Either healthcare providers have not recognized that they are at risk, and certainly these are not people that are likely to end up in a traditional treatment environment because they don't have a diagnosis. And it's very important as you think about, and if you are thinking about implementing SBIRT in your site, that we have a tendency to want to drift to the most intractable patients, to the most obviously harmfully involved patients. So there's just a natural desire to drift towards those people who are easy to identify, who are likely have a substance use disorder, who need treatment, who are in all kinds of psychosocial or healthcare trouble, and because that's what we've sort of always done. It's important when we talk about implementing SBIRT that we don't lose sight of the fact that we will identify those people and we will be able to assist them potentially in accessing the care they need. But that our primary goal really is to ensure that we are able to identify those yellow light folks, those at-risk population, and provide them with a service that historically they have not got, and then be able to assist them in making new choices about their substance use behavior. So SBIRT, because we're using a public health model and because we believe substance use is a public health problem, we are going to learn from healthcare. And as all of you know, the healthcare system routinely screens for potential medical problems. That could be cancer, diabetes, hypertension, there's a variety of others, and then provides preventative services prior to the onset of acute symptoms, and then we can delay or preclude the development of anything chronic. A great example of this is the blood pressure. If you go to the doctor 7 times this week, you'll get a blood pressure taken 7 times. Now, the blood pressure does not diagnose anything. It merely screens for hypertension, because hypertension can indicate a variety of potential other cardiac problems. And so it doesn't diagnose. It takes only just a minute or two, and it effectively tells a provider whether they should ask more questions about the results of that screen. Now, it may be that a person's blood pressure is a little bit high, or let's say it may be that the blood pressure is normal, and the physician would probably provide feedback, much like SBIRT would do if we were a low-risk user, and say, your blood pressure is fine, and that's great. If that blood pressure is a little bit high, the provider may say something like, your blood pressure is up a little bit. Are you under a lot of stress? Are you smoking? What's your diet like? Do you eat a lot of salt? Are you exercising, etc.? And they might look for some reasons why this person is mildly hypertensive, and then provide some input about some changes a person might make or some things a person might do to alter their behavior to effectively deal with their hypertension. If someone's blood pressure is extremely high and very abnormal, they have the potential to then refer to a specialist for a diagnosis of some kind, which may be, arterial sclerosis or something else, and then to provide that really time, cost, and labor-intensive services for a person who really needs it. But again, what SBIRT does basically is just models this. What we say is we can identify people who are not at risk. We can identify people who are at risk for psychosocial or healthcare problems, and then we can identify people who clearly need additional care. And we can do this as fast as a blood pressure. It's not a complicated process. So again, the SBIRT concept is to use a public health approach to universal screening for substance use problems. And what that means is our belief and our approach is that every single patient who walks into a medical facility should be screened for high-risk substance use. And for instance, in the hospitals that we work at here in Georgia, we provide universal screens to about 3,000 patients per week. And we do that by asking two very simple questions. If you're a male, we ask you, at any one time in the last 12 months, have you had more than 4 drinks on one occasion? That's the question that we ask. The second question we ask is, at any time in the last 12 months, have you used an illegal drug or a prescription drug other than how it was prescribed by your physician? Those are the two questions we ask. And we ask women, again, the same rule-out questions, but it's for women, it's 3 or more drinks on one occasion. So in 30 seconds, by asking two very simple questions, we can immediately rule out non-problem users. In addition, what we can do is, for those people who are positive, in other words, say, yes, I have drank over those limits in the last 12 months or used an illegal drug or a prescription drug other than prescribed, we can then ask a few more questions to identify their level of risk. And through that process, then we can identify patients who would benefit from brief advice or a brief intervention, and also clearly identify those patients who would benefit from higher levels of care. Now, the universal screen really does only take about 30 seconds. And one of the questions that people ask is, how do you know if people are being honest? Or from the other side, people will not be honest. People just assume that patients will not be honest about their substance use. We have found, and there's lots of data that bears this out, a lot of research that bears this out, that people are remarkably candid about their substance use. And what we have is a myth that has grown up around people being honest or candid about their use, because we've dealt historically, particularly in the treatment arena, with a population that has been referred through criminal justice, and they have a vested interest in potentially being less than candid. What we find that the average person, if asked by a provider about 4 more drinks on one occasion or 3 more drinks on one occasion or 4, then what we find is that does not seem abnormal to them. And so they're not hesitant in saying, sure, I've had more than 4 beers on one occasion, or yes, I've had more than 4 martinis on one occasion. They're not as prone to feel a need to be circumspect about their self-report. And so we find that people are routinely fairly straightforward about their use when we ask those two questions. And again, what we find is our expectation would be that about 25% of everybody we ask should be positive. That would go with our model that says somewhere between 25 and 30% of the population at any one time is either an excessive user or dependent. What we find in our internal research, at least here in Georgia, and we've certainly found this in our project in Washington, that month in and month out, we're always between about 23 and 28% of positive responses when we ask those two universal screening questions. And so that bears out that those questions are actually identifying the folks that we want those questions to identify. Now, there really aren't a lot of moving parts to SBIRT. It's deceptively simple. It's so simple sometimes that it seems too good to be true. One of the things I always remind, particularly medical providers, is that the biggest innovation in healthcare in the last 200 years is hand washing. And hand washing is amazingly simple, but I would submit that it saved more lives than fancy surgeries or antibiotics. And so just washing your hands, as simple as that is, can really be impactful. And SBIRT is that way. It's really quite simple and straightforward, but it really can have profound results. So the moving parts are really pre-screening. We call the universal screen a pre-screen. When we ask those two questions to the patients that come into our 2 sites here in Georgia, And we ask those to everybody, unless you're unconscious or psychotic or in custody. We basically ask that to every person that walks in the door, those 2 questions. And about 25% of those folks are going to respond in a positive way. We're going to provide a more in-depth screening for those folks. That screen takes anywhere from 2 to 5 minutes maximum. Excuse me, about 2 to 5 minutes for that screen. So so between pre-screening and a full screen, we've spent maybe 6 minutes of time. When we ask the folks, when we do a full screen for folks, and then we also have specific cutoff points. Some people will fall out at that point, and we're really just going to give them some brief advice. We're going to say, it looks like you're doing pretty good, and here are the safe limits. This is just to provide them with some information and some really quantitative measures that they can gauge their use by. For those who are scoring higher, then we're going to provide a brief intervention, and that can be anywhere from 5 to 15 minutes of basically a simple discussion, generally based on motivational interviewing, a simple discussion about their score, what their score means. Would they like to make changes now that they have new information, and what changes would those be, and how would they do it? It's really quite simple and straightforward what we do, and it's not dissimilar from what a doctor might say generally if someone has high blood pressure. Are you under a lot of stress? What's your diet, your exercise, your smoking, those kinds of things. And then that provider may offer a menu of options to change the status of the blood pressure. Have you considered changing your diet? Have you considered reducing your salt intake? Would you like some information on smoking cessation, et cetera? That really is a brief intervention. And so it's not markedly dissimilar from what medical practitioners have done historically when discussing lifestyle-related problems with their patients. We have a couple of other moving parts, brief treatment, and these are for folks who are at moderate or high risk, or potentially are even diagnosable with an abuse diagnosis or a dependence diagnosis. But these are folks that are at the higher end of the scale who could benefit from something more ongoing, but not something as intense as traditional treatment. And then lastly, of course, we have traditional treatment for those folks who are dependent and who are willing to engage. Of course, we can't force anybody to enter treatment, but we do have excellent data from Washington State, and we found that people were somewhere between 2 and 4 times more likely to enter traditional treatment if they needed it, if they had SBIRT first. And so we're not only able to identify those people fairly quickly, we're also able to assist in motivating them to seek a higher level of care that they likely need. So as we move towards talking a little bit more about implementation, key point 1, the healthcare system is moving towards an integrated system approach, and that includes the consideration of lifestyle-related illnesses. And problems associated with substance use are based in lifestyle choices. And for me, this I think is distinct from, let's say, a behavioral health problem like depression or other mental illness that are not choice-based. And the differentiation I make there may be small, but I think it's relevant in the fact that when someone uses alcohol excessively, that's a choice that they are making, and it's lifestyle related. If they make a difference, if they make a choice to change their lifestyle to make a different choice, then those problems, then they can become low risk, no risk, and those problems that they either have a potential for or are starting to encounter will dissipate. Certainly obesity is a lifestyle-related illness. Obesity can be changed with a change in behavior. And I find this to be distinct from something like depression or schizophrenia or anxiety, something that is biochemical, something that is potentially brain-based, and people don't choose that. They're not making a choice to get up and be depressed. The depression just falls on them, and then they're in a position to have to deal with it, as opposed to a lifestyle-related illness like substance use. And so people can make choices to change their behavior, and when they change their behaviors, their chances for problems to their likelihood of encountering negative results goes down. Also important here to know that the Affordable Care Act really has started to focus, and all of our health care discussions really these days really fall on the side of prevention. In some ways, we've had a sick care system in our country waiting for people to get ill and then treating them, and not really a health care system where we try to keep people healthy. And so we know that we're really moving towards more screens, whether those are mass mammograms, whether it's PSAs, whether it's screens for diabetes or depression or whatever it might be. We're really looking for ways to identify things early, and then to treat them earlier, intervene early, so that either problems don't result or those problems are small and they don't become chronic conditions. And clearly integrating behavioral health and lifestyle health into medical practices. The second key point is that if you are considering designing, planning, or implementing an SBIRT project, is to recognize that it's really a creative endeavor and it's not necessarily a logical one. And by that I mean we can create, and I have actually done this, we can create flowcharts and inputs and throughputs and outcomes and objectives and all those things. And what will happen is once you start to implement your project, you'll find that all of those things, most of those things, if not all of them, will go out the window, and that you have to find ways to be creative in how you implement this process. So I'm not a huge fan of again making a flow chart and inputs and outputs and throughputs and those things, because what I found is that in the real world, while that looks really good on paper, in the real world it's much more creative rather than logical in some ways. The third key point here is that SBIRT has to be integrated. It must be integrated into the ongoing operations of a site. And that implementation without integration, it's going to create pushback, it'll create barriers, and a general sense that SBIRT is somehow too time or labor intensive to be of value. So it'll be seen that way, or it will be seen as sort of an add-on addendum service that really isn't part of the mission of the organization. Everybody understands that blood pressures make sense in a medical environment. Not everybody understands that screening for substance use issues makes sense. And so unless SBIRT is integrated into the operation where it becomes a seamless part of what's done, it'll either be seen as an additional sort of ancillary service that's not really necessary and should only be done when there's time to do it, or it'll create all sorts of other problems with pushback and lack of interest in actually doing the project. So when we start to talk about implementation specifically, and this is true in any site, but we're specifically talking about emergency departments, but this would be true in any site where we were planning on implementing SBIRT. You have to answer about 6 or 7 basic questions. And the first is, who is the population that you're going to serve? And I'll go into these more fully as we go forward. Who is the population that you're going to serve? Who will provide the services to that population? What tools are they going to use to provide the services? When will they be provided? Where will they be provided? What kind of records are you going to keep, and how are you going to keep them? And then, as important as all these, how are you going to bill? We'll talk a little bit more about billing, and in fact, we have another webinar tomorrow specifically geared towards reimbursement billing and other business practices that I would encourage you to attend. So these are the 7 basic questions that anybody who's starting an SBIRT program is going to have to ask. And so what I encourage sites, when I work with sites, I always encourage them to conduct a facility needs assessment. And this is generally fairly simple because this data usually exists on the ground, and it's just really putting it together. And so you want to look at patient demographics, patient flow through the facility. How long do procedures take? How long is a person usually there when they come to your facility? How long does it actually take to do a screening and a brief intervention? Are there internal or external policies that would either preclude or facilitate doing SBIRT? What kind of staffing resources are available to do the work? Are there fiscal needs and are there fiscal resources? Is there space to conduct this work? Is this going to be something that your institutional review board will need to comment on? And then technology using boy, my mind just went blank. Using electronic medical records to track interventions, to track scores on screening instruments, to build those kinds of things. So really being able to look at your facility and knowing who your patients are, the flow through your facility, how long these services might take, if there's policies that are helpful or not, staffing, fiscal resources, those things, very important to do. And it usually these again, this data is fairly readily available. So, and here's a quick implementation checklist. Complete a needs assessment, and again, that can be done fairly quickly, and again, that information is generally readily available. The next thing you want to do is educate your staff. There's lots of information about SBIRT. There's lots of randomized controlled studies have been done. We also have tons of field research that we've done that shows that SBIRT really is effective, that it assists people in reducing their substance use, increasing their abstinence, accessing treatment, improved healthcare outcomes, reduced costs. And so there's lots of information about why SBIRT is a real positive healthcare initiative, why it should be done and why it can be done. And there's broad support. Everybody from the American Medical Association to the National Highway Traffic Safety Administration endorses SBIRT as a valuable resource to deal with the public health problem of substance use. So once you do that needs assessment and begin to educate your staff, then you're really going to do those things that we just talked about, which are defining your target population, developing a screening protocol, developing a protocol for brief interventions, how you're going to chart, how you're going to bill, how you're going to collect data and store, and then anything that has to do with quality improvement. So to define your population, this may be the easiest part, is which patients will you screen? And it's just that simple. For instance, in our sites, and this was also true to our sites in Washington, it was anyone over the age of 18 who was not unconscious, in police custody, obviously psychotic, or too intoxicated to answer questions effectively. So otherwise, if you are over 18, we are going to ask you at admission the pre-screen questions. And so that's I'll talk a little bit more about how that gets integrated into the process, but that's really I'll talk about that now. How we do it at my sites here in Georgia is we have, when a person presents to the emergency department, there's a series of questions that the admitting nurse will ask, and that's everything from what is your address, do you have insurance, are you allergic to anything, to our 2 pre-screen questions. Those are built into the electronic medical record, and those questions are just part of the series of questions that she asks or he asks every single patient that walks through the door. And so once those are embedded into the standard format of an intake process or an admission process, then they just become rote. People don't even think about it. They're just going through a list, a series of questions that they're going to ask anyway, and they ask these questions. So we find that once those questions are embedded, again, that just becomes a part of the ongoing operation, and it's fully integrated right at the front end. Now, there are other choices you could make. You could just pick people that are clearly seem to be identifiable. You could pick people who come in who have alcohol in their breath, for instance. People who are there for a specific problem that is likely alcohol or drug related. There's a variety of ways to sort of define your population here. Of course, we encourage the universal screen because we believe that it's the best way to identify that broad range of excessive users, particularly who frequently fly under the radar. And of course, the question you ask is which patients will you exclude from screening, and I've discussed the ones that we exclude. But that doesn't mean that we might not screen those folks later. For instance, if you come to one of our hospitals in trauma, let's say, and you're already medicated with medication, but you're admitted, we will talk to you the next day and do a screen the next day. And so just because you miss a person initially at their admission or when they're being vetted by a nurse prior to admission, it doesn't mean that you don't have access to those folks later. Develop a screening protocol. I think the big question, and one of the questions we wanted to answer today was who actually does this work? And what we have found, at least in my experience, and this is anecdotal, but in my experience in implementing in a number of sites, that the more there's basically just 2 or 3 models here, and I'll talk about those. But the more this can be sort of rolled out and distributed among more than one person, the more likely it is that no one will find it a burden. For instance, as I said, our triage nurse or our admitting nurse is the one that does our pre-screen. If that pre-screen is positive, then our staff is alerted through the electronic system that there's a positive score, and we are able to recognize that there's a positive score. But so after that pre-screen, the question really is who is going to then see that patient if the screen was positive and we want to actually talk to that patient more and potentially do a brief intervention. Now that could be other nursing staff. That could be at that point the triage nurse, if the pre-screen is positive, could potentially hand the screening tool to the patient and let them self-administer that test and then hand it back to her. Maybe at that point that would go to the other nurse or to the nurse that does the blood pressure and those things. Maybe she could talk to the patient. That's possible. If you're in a site that has existing behavioral health staff, that's a possibility that the patient basically is handed off to that behavioral health staff to be seen. The health educator model is something that's very popular. That's the model that we use here in Georgia, where we have specific staff whose function is to do full screens and brief interventions and referral. Perhaps there's a substance use counselor on staff. Injury prevention is a potential here, or if you have social workers on staff. And there really is sort of 3 models to who's going to do this work. There's a carve-out model that says you're going to have dedicated staff that does this. They're a health educator, they're a substance use counselor, they're a behavioral health staff, a social worker, whatever it might be, and they specifically do this work. You have another model that's, so you have that specialist model, and then you have another model that is more of a generalist model where you say, for instance, potentially, let's say the triage nurse does the pre-screen, the nurse that does the blood pressure and other things does the full screen, and then the physician actually does a brief intervention based on the information that's gathered on those screens. So there's not a right or wrong way to staff this this function. But again, what we found is the more people, in other words, if you have the nurse do a pre-screen, the triage nurse do a pre-screen, another nurse do the full screen, and then the doctor or behavioral health staff do the brief intervention, nobody finds this terribly onerous. because they're not spending all of their time sort of engaged in doing this. And again, this is a 15 to 20-minute process from start to end. You also have to decide when and where you're going to do it, and it could be done in triage, depending. Part of why we always encourage people to do a needs assessment is you may find that people sit in your waiting room for 45 minutes before they see a physician. That's a fine time that if there's been a positive pre-screen to pull that person into a quiet room or an office and do a fuller screen and potentially a brief intervention. We do all of our work bedside, and really that's how most of SBIRT is conducted. Once a person is placed in a room, for instance in an emergency department, once they're placed in a room, there's always adequate time for our staff to go in, complete a full screen, and then do a brief intervention or referral, whatever they might do. So you can do it, but while they're getting care, for instance, a physician could be sewing up a cut and doing a brief intervention. This could also be done pre-discharge, when you're doing the discharge information to a patient, talking about, let's care for a wound, let's say, that a nurse at that point could actually engage that person in a fuller screen and a brief intervention. So there's a variety of ways to roll this out and to integrate it. And again, that's why it's a really creative process, and that's why looking at patient flow, looking at the complement of staff that you have in your specific facility, looking at time lengths and those kinds of things are really important up front, because they'll really start to answer some questions about who and when and where we can do this work. And remember, it's not time dependent. It's very straightforward. The pre-screen takes maybe 30 seconds, the full screen 2 to 5 minutes, and then a brief intervention 5 to 15 minutes. So it's not a particularly time-intensive process. For a screening protocol, what tools will you employ? And there's lots of tools out there that can be used. Some sites just say if somebody has a positive BAC, then we're going to give them a brief intervention. That's their screen. The Alcohol Use Disorders Identification Test, the Michigan Alcohol Screening Test are both excellent tests. We personally favor the audit. At least I personally favor the audit. It's 10 questions. It's very straightforward. It's very quick. It's valid and reliable, and it could be patient self-administered as well. So it's very easy to either verbally give to the patient or to have the patient complete that themselves. You could use a combination. For instance, someone that has a positive blood alcohol content, then give them, for instance, another screening tool like the audit. You could use the drug abuse screening test for those people who score positive on the drug question that you ask at pre-screen. The ASSIST is a longer tool developed by the World Health Organization. The CRAFT is an adolescent screen. You could use a combination. We certainly do. We would potentially use the audit if a person just responds positively to the alcohol question. We would do the audit. If they respond positively only to the drug question, we would do the drug abuse screening test, the DAST. If they respond to both, we could do both screens. But again, those screens are very quick. And all of these screens are valid, reliable, and very, very simple to use. And they're all also pretty much they're all public domain as well. So there's no cost to accessing these tools. So once the person has been identified through a pre-screen as positive and giving a full screen, then the question is what level of intervention will be required at that point. We give all of our patients, regardless of where they fall out on a full screen, for instance, if we do the audit, regardless of where they score on that screen, they will get a brief intervention from us. You can have dedicated staff that do that. You can certainly have social workers, the doctor, a psychologist, a chemical dependency professional, a chaplain, a nurse, etc. There's no rules to necessarily about who can specifically conduct this this service. There may be some questions about There may be some questions about billing and who can conduct the service and then be billed, can then be reimbursed for it. But in general, there's some research out there that shows that doctors or physicians are no more productive at doing this than, let's say, a chemical dependency counselor. And so there's not, it's about having the skill in motivational interviewing or cognitive behavioral therapy, those kinds of things that really make a difference here, as opposed to level of education and those kinds of things. So who's going to actually do that brief intervention? And again, if the screener, if the person who provides the screen isn't the same person who can actually will come in and then speak directly to the patient about in the intervention phase, then how are you going to access, how is that person going to know a person was positive, those kinds of things. So those are just flow questions that need to be answered. What support materials will you use? We use a variety of different things. We use handouts that are readily available from Substance Abuse Mental Health Service Administration that are free on alcohol, on other drugs, depending on what a person is using. We also have some other motivational interviewing tools that we use that are either easy to develop or public domain, things like a readiness ruler. And some things like that. We also use a pyramid to show people where they fall out compared to other people on their score and what that means. So there's a variety of sort of visual kinds of materials that or handouts that can be used. And again, that's just a decision that needs to be made. And then, of course, patient handouts. And, of course, you have to ask the question, when and where will the brief intervention be conducted? In our model, again, the triage nurse does the pre-screen. We're informed of a positive result. My staff goes in, does the full screen, and then does the brief intervention and the rest of the work, and they do that bedside. So if the physician comes in during the interview, they walk out until the physician is done. But generally, what we find is that 15 or 20 minutes that we're going to spend with the patient, that there's always adequate time. No matter how fast an emergency department moves, there's literally almost always time for us to have access to the patient and to spend time with the patient going over the results of the screen, doing the screen, and doing a brief intervention. And, of course, it can also be done pre-discharge. So some things to consider when you start to think about doing SBIRT at your facility. Who, how many, when, and where you screen will affect the time requirements for interventions. And this is actually fairly straightforward. If you have 500 people, well, let's say if you have 100 people come through your facility every day, assume that 25% or 25 of those people will be positive on a pre-screen, which immediately, so you can just pretty much assume that. It may be 23, it may be 28, but it's always going to be right around 25%. And so you know that if you have 100 people come through, you're going to have 25 people that need a full screen. If you have 200, it's 50, et cetera, and it's pretty straightforward math. But the second thing you need to consider is the typical patient services sequences and length of stay will influence when you can do this work. And so if there's a long delay between seeing a triage nurse and actually going to a room where you will see a physician, that's potential time that this work could be done. Generally, once a person is placed in a room, most sites will have an idea of how long it'll be before the doctor actually arrives in that room, so that may be a time. It may be in between other service sequences. For instance, the patient is going to, it needs a x-ray, let's say. So there may be time in between when you order when the x-ray is ordered and when the x-ray can actually be conducted, or the phlebotomist comes in, et cetera. So knowing sort of the flow of the patient, and the service sequences, length of stay, all those things, very important. And also the kind of intervention you do is going to affect how long this takes. For instance, you could do just the triage questions and the pre-screen questions, the one alcohol and one drug question, and then dispense with a full screen and just assume that everybody who answers positive to those questions, one of those questions, needs a brief intervention. So you could cut out that broader screen, an audit or a DAST or whatever tool you use, and just say that if you a score positive on that binge drinking question, that you've, for a man, more than 4 drinks, for a woman, more than 3, then we are going to do an intervention with you. That could reduce some of the time necessity there. But there's also ways to increase or decrease the length of time that an intervention takes, and that's generally we can assist people with training to really know exactly how to sort of conduct an interview that may be either longer or shorter. Certainly the question is, are you going to provide this service 24 hours a day? If you're a 24-hour facility, are you going to have shift coverage? Those kinds of things, and that can affect if you're particularly have standalone practitioners like a health educator to do this work, that's their only function, then how many of those people you need. That can also affect budget, things like that. So it's important to sort of understand how you're going to, who's going to do the work and how you're going to mold this into your existing operation. And of course, whether you have the person who does the intervention also do the screening and those kinds of things can affect time. For instance, if you have a nurse do a screen and then they have to notify someone else, like let's say a social worker, to come and do the brief intervention, there can be some time lags in there and things like that. So all of these things can really impact the length of time that the entire process takes. But perhaps the most important thing on this page is to always remember that about 25 people out of 100 are going to be positive on that pre-screen, and you can work the numbers from there. Certainly a charting protocol. There's lots of questions still exist. For those of you who have been in the substance use field for a while, you know about Federal Regulation 42 CFR Part 2, which talks about all substance use records being confidential. And you're also certainly familiar with HIPAA. And so there are lots of questions out there around HIPAA and 42 CFR Part 2, which I'll talk about in just a minute. But charting can be important here, and so are you going to keep a chart note? What information? What will you or won't you include? All those kinds of things. Now, what I can say is that at our sites, we're completely integrated with the electronic medical record. So when the nurse does a pre-screen and it's positive, that's recorded immediately in the electronic medical record. When we do a full screen, then subsequent to doing that screen, we record the score and what we did with the patient, whether we provided them a brief intervention, whether we made a referral, whether we gave them screening and feedback. It's very brief, but it's just a small little chart note in the electronic medical record that says we saw them, that this was their score, and this is the service that we provided. And again, that's very site-specific. Some of that may be driven by internal policy. Some of that may be driven by billing policy. For instance, doctors will sign off on our staff's notes so that we can bill, for instance. So internal policy can drive that. Reimbursement policy can drive that. And so there may be other sort of issues down in the weeds around charting that's important, that are important for you to consider here when you're thinking about adding this to an electronic medical record or keeping a chart note of some kind. Certainly a billing strategy, and here's my plug for the webinar tomorrow. There's a reimbursement-specific webinar tomorrow, and that's September 12th from 3 to 5 Eastern Time, and I've got the link right there on the slides. And I'm assuming that if you're on this webinar that you've got the information for that webinar too. And so I'm not going to spend a lot of time going over reimbursement because that'll be really fleshed out for you tomorrow and really provide you with some good information there. Monitoring and evaluation. Depending on, I think most of us know that the Joint Commission has come up with standards for SBIRT, and they've put that as part of their certification and accreditation stuff that they do. And so there are some specific guidelines for what needs to be recorded and not. If you're not using, if you're not JCAHO accredited, or if that's not one of the standards you're going to use in your accreditation, you don't have to, clearly don't have to worry about that, but those could be some pretty good guidelines for what you might want to capture. And certainly at our sites, what we do is we look at how many patients actually came through the door. So basically, how many patients were eligible? How many of those patients actually were pre-screened? How many of those were pre-screened positive? And of those positives, how many were actually seen by our staff? And this gives us enough information to actually do quality improvement. We don't need to know much more than this to be able to actually improve our ability to see more people, to do the job more quickly, and things like that. So, and again, this is very site-specific, and there's no hard or fast rules that, except potentially the Joint Commission information about how you monitor or evaluate your project. But clearly, you should want to know what are your outcome measures. Are there training requirements for providers? And how do you ensure fidelity? One of the things that payers will want to know is how do you ensure that there's some fidelity to a specific model? And so being able to document how fidelity is ensured can be very important. And it's something that might easily be forgotten, but that can be a sort of an important caveat here to making sure that the work is done. Not only is it you know, faithful to the model, but that then you're achieving reasonable results. Some legal issues fairly quickly. I believe in 38 states, and it may be less now, but in 38 states, insurance companies can refuse to pay for treatment for injuries that are alcohol or drug related. These are called UPPL laws, and again, they're on the books in most of the states. And while insurers don't sort of go to this length all the time, they certainly do, and I've heard terrible horror stories about people who were, let's say, were injured. They were driving under the influence. They got in a terrible traffic accident. They were in intensive care for 6 weeks, and the insurance company refused to pay. And so this is basically an external policy that needs to be considered on a variety of levels. First of all, from just a provider level, this really encourages poor patient care, because either it encourages a provider to ask about substance use and not record it, or not to ask, even if they believe that there's a substance use issue, if a payer can refuse to pay. So that can be an important thing to check into in your specific state and what those laws say, and if those laws are on the books. Secondly, again, I talked a little bit about 42 CFR Part 2. Nothing about HIPAA impacts this. Generally, when a patient comes into a facility, you give them the HIPAA form, they sign it, and all of HIPAA will apply to this information as well. There is some question about 42 CFR Part 2, but if you look at the specific language in that law, it says, and this is a quote, if substance use information is collected primarily for treatment services versus medical care, it must be stored separately from the chart and needs a separate release. Clearly, SBIRT in a medical environment, whether that's a primary care practice, an FQHC, an emergency department, a trauma center, we are collecting this information for medical care, not for treatment services. Therefore, 42 CFR Part 2 should not apply. And so, but that's a question that does come up. Certainly consulting with your legal department is a reasonable thing to do. But again, the language in the law is pretty specific that if we are in a medical environment asking questions so we can provide effective medical care, and including a brief intervention to reduce use to improve positive outcomes, then that is not protected by 42 CFR Part 2. And that is the end of the show. So what I want to do, I think, is I'm going to return it back over to Misty, and then we're going to open it up for questions.